Good morning, everyone. I'm Dr. Rajapriya, Assistant Professor in Department of Obstetrics and Gynecology in SLIMS, Puducherry. Today, we are going to discuss about hypertensive disorders in pregnancy, especially preeclampsia. As we all know, it's the most common medical complication in pregnancy, with the incidence of 7 to 15%, and the related increased prevalence is due to the predisposing factors like chronic hypertension, diabetes, and obesity. In addition to hemorrhage and infection, hypertension forms a deadly triad. Associated with this, fetal outcomes will be very bad, like fetal growth restriction, low birth weight, spontaneous or iatrogenic preterm delivery, respiratory distress syndrome, NICU admission, and so on. So, coming to the definition part, hypertension in pregnancy is defined as systolic BP of more than 140 mm of mercury or higher, or diastolic BP of more than 90 mm of mercury or higher. The measurement should be confirmed at least 2 occasions, 4 to 6 hours apart, within a maximum period of 1 week. So for accuracy, it's better to use mercury sphygmomanometer, and the upper cuff size should be 1.5 times the upper arm circumference. Patient should be in upright position with right arm supported in the horizontal position at the level of heart. After some 10 minutes or longer rest period, they should not use tobacco or caffeine within 30 minutes of preceding measurement. Coming to the proteinuria. So it's defined as urinary excretion of 300 milligram per deciliter or more of protein in 24 hours urine collection, or urine spot PCR of more than 30 milligram per millimole. So it usually correlates with the more than 30 milligram per deciliter, that is more than 1 plus by qualitative estimation by reagent strips. At least 2 random samples should be positive. It should be done 4 to 6 hours apart with no evidence of urinary tract infection. So coming to classification of hypertensive disorders. So we have so many categories in this. The first thing is gestation hypertension. Next is preeclampsia, eclampsia, chronic hypertension, essential hypertension, secondary hypertension, preeclampsia superimposed on chronic hypertension. Coming to gestation hypertension part. So it's defined as new onset hypertension develops after 20 weeks of gestation or during labor or first 24 hours postpartum without proteinuria or any other severe systemic features of preeclampsia in a previously normotensive non-proteinuric woman, and BP should resolve within 3 months of postpartum. So severe GHTN, severe gestational hypertension is one with systolic BP of more than 160 mm of mercury or diastolic BP of more than 110 mm of mercury or both. Next is preeclampsia. It's a disorder of pregnancy along with new onset hypertension. There will be proteinuria. It's most often seen after 20 weeks of gestation. Near term also, we can see it more frequently. The following features are also one of the diagnostic criteria for preeclampsia. They include thrombocytopenia with platelet count of less than 1 lakh, impaired renal function with elevated liver enzymes to twice in upper limit of normal concentration, severe persistent right upper right quadrant pain or epigastric pain, not accounted by alternate diagnosis, with renal insufficiency with serum creatinine concentration more than 1.1 or doubling of serum creatinine concentration in the absence of other renal diseases, presence of pulmonary edema, new onset of headache, unresponsive to acetaminophen, or not accounted by alternate diagnosis or with visual disturbances. Coming to the eclampsia, these are conversions occurring in a patient with preeclampsia and are more severe manifestations of this disease. So, one more syndrome in this hypertensive disorder of pregnancy is HELP syndrome. It is nothing but hemolysis, elevated liver enzymes, and low level of platelet. The features include hemolysis with abnormal peripheral blood smear, with bilirubin more than 1.2, elevated liver enzymes, twice the upper limit of normal, and thrombocytopenia with platelet count less than 1 lakh. Coming to chronic hypertension part. So this is defined as a hypertension present before 20 weeks of pregnancy, or that is diagnosed preconception itself. It should be documented at least 2 occasions, at least 4 hours apart. And the BP elevation will be persisting even after 12 weeks of postpartum. And it is also considered as chronic hypertension retrospectively. In this chronic hypertension, we have 2 etiologies. They are essential hypertension and secondary hypertension. Essential hypertension is one when there is no apparent underlying cause for chronic hypertension is found. The secondary hypertension is due to some renal parenchymal disease or scarring, vascular disease, endocrine disorders, or coagulation of aorta. Next is preeclampsia superimposed on chronic hypertension. So it's diagnosed when one or more features of preeclampsia develop for a first time during pregnancy after 20 weeks in a woman with pre-existing chronic hypertension. Next, we are going to see NICE guidelines of mild, moderate, and severe hypertension. So, mild hypertension is one in which systolic BP is 140 to 149 mm of mercury, and diastolic is 90 to 99 mm of mercury. And moderate hypertension is systolic BP with 1 to 159 mm of mercury, and diastolic BP is 100 to 109. And severe hypertension is one with systolic BP more than 160 or more, diastolic BP with 110 or more. So we come to the proper part, preeclampsia. It's a disorder of pregnancy. It's a disorder of pregnancy with new onset hypertension, which occurs most often after 20 weeks of gestation and frequently near term. It's often associated with proteinuria. It's a multi-organ disease process of unknown etiology characterized by de novo development of hypertension and proteinuria after 20 weeks of gestation, sometimes progressing to multi-organ cluster of varying clinical features. Mostly it will be a triad with hypertension, proteinuria, and edema. There is one more term called atypical preeclampsia. The traditional criteria for hypertension proteinuria may not be seen in these patients who develop signs and symptoms or other lab abnormalities of preeclampsia or eclampsia stadium. The incidence of preeclampsia is 2 to 7%. So the following are the risk factors associated with presence of preeclampsia. The first one is couple related, like nulliparity or primary paternity, limited sperm exposure, pregnancy after donor insemination, donor egg, donor embryo, maternal or pregnancy related, like extremes of age group, age less than 18 years or more than 35 years, obesity with BMI more than 35, and insulin resistance or gestation diabetes, smoking, pregnancy conceived by assisted reproductive technology, multi-fetal pregnancies, history of preeclampsia and previous pregnancy, maternal low birth weight, family history of preeclampsia, and pre-existing medical diseases like pre-gestational diabetes, chronic hypertension, renal disease, maternal immunological disease or SLE, pre-existing thrombophilia or Aplar syndrome, obstructive sleep apnea. These all contributes to risk factors of preeclampsia. So in preeclampsia, again we have mild and severe preeclampsia. Mild is otherwise called non-severe preeclampsia when the diastolic BP remains below 110 mm of mercury and systolic BP remains below 160 mm of mercury. It is found to be mild preeclampsia. Severe preeclampsia is one with severe hypertension or the symptoms are biochemical or hematological impairments. Severe preeclampsia is confirmed by the diastolic BP of more than or equal to 110 mm of mercury on 2 occasions, or systolic BP of more than or equal to 160 mm of mercury on 2 occasions, together with significant proteinuria, at least 1 gram per liter. The other severe features include severe headache or visual disturbances of scotomas, suggest of impending eclampsia, epigastric upper right quadrant pain, features suggest of hepatocellular necrosis, ischemia, hemorrhage or edema causing stage of the Gleason's capsule associated with elevated liver enzymes. Thrombocytopenia, features of platelet activation and microangiopathic hemolysis induced by severe vasospasm causing HEB syndrome, cardiac or renal dysfunction or FGR, fluid growth restriction in the presence of preeclampsia. Coming to the etiopathogenesis part, 2-stage disorder hypothesis we have. The exact nature of the primary event causing preeclampsia is not known. Abnormal trophoblastic invasion of spiral arterioles and inappropriate endothelial cell activation associated with exaggerated inflammatory response are the key features in the pathogenesis of preeclampsia. This trophoblastic invasion will be taking place in 2 stages. The primary stage, which involves abnormal placentation. In normal pregnancy, the walls of spiral arteries is invaded by endovascular trophoblastic cells. And this migration transforms these small musculo-elastic spiral arteries into large arches channels that carry a large amount of blood into the intravenous space and are resistant to the effects of vasopressor agents. So these visual changes are incomplete in case of preeclampsia, and the trophoblastic invasion affects only some of the spiral arteries and does not progress into the myometric portion of the arteries. It is incomplete trophoblastic invasion, and they respond to vasomotor influences as well. The second stage involves conversion of the uteroplacental circulation into maternal systemic uteroplacental insufficiency into maternal systemic response syndrome of preeclampsia. The stage is modified by pre-existing maternal conditions like cardiac renal disease, diabetes, obesity, and hereditary influences. Next is vascular endothelial cell activation. In response to the present factors induced by ischemia, a cascade of events will be taking place to finally result in endothelial cell injury. Cytokines like tumor necrosis factor alpha, interleukins contributes to oxidative stress by formation of free radicals and self-propagating lipid peroxidases that enter the endothelial cells, modify the natric oxide production and interfere with the prostaglandin release. So these oxidative stress along with the lipid and macrophages as microvascular coagulation manifested by thrombocytopenia, increased vascular permeability, manifest as edema and proteinuria. Next is angiogenic imbalance. It's displayed by the production of excessive amounts of anti-angiogenic factors by the trophoblastic tissue. Soluble FMS like tyrosine kinase protein produced by the placenta acts by binding the receptor binding domains of the VEGF, vascular endothelial growth factor, and placental growth factor. So increased metal levels of soluble FMS kinase levels inactivate and decrease circulating levels of VEGF and placental growth factor concentration results in the endothelial cell dysfunction and angiogenic imbalance. Coming to the genetic factors. Hereditary predisposition is likely the result of interaction of multiple genes from both paternal and maternal side. Increased pressure response. In pregnancy, normally there will be refractiveness to the pressure response of angiotensin II. Women predisposed to preeclampsia will be having increased vascular reactivity to infusion of angiotensin II and norepinephrine. Nitric oxide. The nitric oxide is a potent vasodilator, as we all know, produced by endothelial cells from L-arginine. Preeclampsia will be assured with decreased endothelial nitric oxide synthase production. Prostaglandins. The blunted pressure response in the normal pregnancy is due to production of endothelial prostacyclin. In preeclampsia, there will be decreased production of prostacyclin, PGI2, made by the phospholipase A2. The following are the material changes we will be seeing in preeclampsia. The first is hemodynamic changes. In mild preeclampsia, there will be increase in the maternal cardiac output, then increased peripheral resistance. In severe preeclampsia, there will be switch to normal or decreased cardiac output, the elevated peripheral resistance due to systemic vasoconstriction. There will be high cardiac output along with increased peripheral resistance, results in traumatic intravascular hemolysis. That is microangiopathic hemolytic anemia will be formed. Increased sympathoadrenal activity mediates increase in the cardiac output also. So there will be decrease in the renal perfusion and increased hydrostatic pressure and proteinuria induced by decreased oncotic pressure. It all precipitate pulmonary edema. And vasoconstriction with leaky microcirculation results in fluid shift into the extracellular interstitial space, causing a depleted intravascular compartment, results in hypovolemia also. Abnormal high hematocrit level is a measure of amount of hypovolemia, results in low birth weight, prematurity, and perinatal mortality. Pathological edema appears suddenly, more often present in facial, periorbital, and presents as accelerated rate of weight gain as well. That is more than 1 kg per week or for 2 to 3 weeks or more than 2 kg in 1 week. Intravascular volume changes. Hemoconcentration will be the hallmark of severe preeclampsia and eclampsia. Hypovolemia will be assured with this FGR, oligo, and preterm labor. There will be changes in the peripheral resistance also. A pattern of decreased vascular resistance to the pressure effects of angiotensin II will be present in case of chronic hypertension. And hematological abnormalities include thrombocytopenia, as we already discussed. It will be occurring due to increased platelet activation and aggregation and consumption. Over thrombocytopenia, that is platelet count less than 1 lakh, indicates severe disease. And delivery is advisable as platelet count continues to fall, and it only improves after some 2 to 3 days of delivery, reaching normal levels. After some 3 to 5 days. Levels of factor 8 plasma clotting factors decrease and fibrin degradation products are increased due to consumption coagulopathy. The more serious hematologic complication of preeclampsia is HELLP syndrome. It's a manifestation of microangiopathy hemolysis caused by endothelial cell disruption. The advanced stage of platelet count will be less than 50,000 or so, and LDH will be more than 600. Diagnosis of HELLP syndrome means confirmation of hemolysis either by elevated liver enzymes like LDH levels or by peripheral blood smear and thrombocytopenia. Women with thrombophilia had increased risk for very early onset severe disease before 32 weeks itself than those without thrombophilia. Coming to the renal changes. In normal pregnancy, renal perfusion and glomerular filtration rate are increased. But in case of preeclampsia, there is five-fold increase in renal afferent arterial resistance that results in decrease in renal blood flow and diminished glomerular filtration. In preeclampsia, the hallmark of renal lesion is swollen, maculated intracapillary endothelial cells. This glomerular endothelial cells will be there. In preeclampsia, there will be increased uric acid concentration also and decrease in the urine calcium excretion. Preeclampsia is a major cause of obstetric acute renal failure and it's induced by persisting hemorrhagic hypotension due to obstetric hemorrhage conditions like APH and BPH. Excess hepatic changes, excessive fibrin deposition in hepatic sinusoids that obstruct blood flow and hepatic vasoconstriction mediated by hypoxia causes release of hepatic enzymes into circulation. Characteristic lesion is periportal hemorrhages in the liver and subcapsular hemorrhages. In association with the DAC, there will be major subcapsular hematomas also and is subsequently resulting in liver rupture. In brain, in response to acute and severe hypertension, there will be cerebrovascular overregulation leading to vasospasm, ischemia, cytotoxic edema, eventually tissue infarction. Hyperreflexia and clonus. So in brain, there will be hyperreflexia and clonus are the hallmarks of severe preeclampsia. Vasospasm of the frontal cortex causes frontal headache unrelieved by analgesics. And constriction in the occipital cortex causes visual disturbances, cortical blindness, even retinal detachment can also occur. So coming to the clinical diagnosis part. So first and most important thing is blood pressure elevation. It's a hallmark of preeclampsia and reflects the severity of disease. The common errors while taking BP will be obese patients with regular size cuff and not using same material position in repeated measurements and use of different endpoints to measure diastolic BP. Usually we have to use first cough, fifth sound as a marker of diastolic BP. Next is proteinuria. It's a sign of preeclampsia with more than 300 mg of protein 24 hours urinary protein. Usually correlates with the 30 mg per deciliter or 1 plus daily dipstick in random urine specimen. And there will be the excessive weight gain also and edema. But these are not considered as diagnostic criteria for preeclampsia nowadays. Coming to the signs and symptoms, neurological manifestations of preeclampsia always indicate severe involvement and require immediate attention. Frontal or occipital headache, scotomas. It's a transient perception of bright or black spots that mean progressive diplopia, blood division, even complete blindness also. Occipital blindness, amaurosis, occurs due to occipital lobe vasogenic edema. Blindness secondary to retinal ischemia or infarction skull, Pusch's retinopathy, and retinal detachment. Epigastric pain or right upper quadrant pain is also common in severe forms of this preeclampsia and is often associated with marked elevations of liver enzymes. Brisk deep tendon reflexes can also occur in resulting from CNS irritability. Clonic conversions are also diagnostic of eclampsia. Coming to the laboratory findings part, there will be altered renal function, mild elevation in the renal serum creatinine, radial nitrogen, uric acid levels. There will be hyperuricemia, oliguria, renal failure. It's uncommon unless it is associated with hemorrhage, HELLP syndrome, or sepsis. Changes in the liver function test include elevated AST, ALT, LDH levels, altered PT, APTT, and fibrinogen levels. Hematological abnormalities like elevation of hemoglobin and hematocrit due to decrease in the plasma volume, LDH levels, erythrocytic isoenzyme, thrombocytopenia, serum fibrinogen levels, PT and APTT measurements, and ophthalmic assessment like findings in severe preeclampsia or increase in the vein to artery ratio and segmental vasospasm will be there. Presence of microaneurysms indicate diabetes. Hemorrhage, exudates, and extensive arterial changes suggest chronic hypertension. Shallow and defective trophoblastic invasion. So these are the FGR fetal growth assessment we should done because there is increased risk of variable retardation in case of preeclampsia. Shallow and defective trophoblastic invasion of spiral arterioles is the hallmark of preeclampsia. So this defective presentation will lead to pathological FGR, oligohydranous, even placental abruption also. Uterine outer Doppler will provide assessment of the uteroplacental circulation and its screening test for prediction of FGR also and preeclampsia also in first trimester itself. Abnormal uterine outer Doppler, that is increased PA, SD ratio, and biodiastolic notching, indicates abnormal impedance or resistance to blood flow in the maternal side of placental circulation. And next is umbilical outer Doppler. It provides assessment of placental to umbilical circulation. So abnormally elevated umbilical artery PA, absent diastolic flow, reversal diastolic flow are indicators of worsening in resistance to blood flow in fetal side. In case of elevated umbilical artery PA, it is necessary to assess the Doppler in case of in MCA, cerebral artery flow for the presence of brain sparing effect. If the MCA ST ratio is larger than umbilical artery ST ratio, now it is known as cerebral placental perfusion ratio. Placenta still have adequate reserves and the fetus is not under significant hypoxia or acidosis. But if the CPR ratio falls below 1, it's less than 1, placenta insufficiency has reached to such a severity, the fetus is in increased danger and the blood flow to the brain is affected and decreasing the blood flow to the vital organs. Absent umbilical artery diastolic flow indicates worsening of the fetal situation and beginning of the acid-base changes in the fetus. Reversed umbilical artery diastolic flow reflects latter state of the late stage of the fetal response to hypoxia. Doppler studies of the venous side of circulation is also important in case of FGR. The venous Doppler assessments like ductus venosus, umbilical vein are indicators of cardiac decompensation secondary to hypoxia. Reversed A wave in ductus is significantly associated with increased perinatal mortality. NST and Manning's biophysical profile are most used test to periodically assess the physical well-being, especially in patients with preeclampsia and umbilical artery resistance. The frequency of testing we have to individualize according to the patient condition and baby status. Coming to the management part, the only effective and definitive treatment for preeclampsia is delivery. So we will see the treatment part for mild preeclampsia first. We have to do initial evaluation like CBC, urine protein, LDH, liver enzymes, uric acid, along with proteinuria we should do. Next, fetal evaluation. For fetal evaluation, we should do growth parameters, amniotic fluid index, color Doppler, fetal surveillance we have to do. The first step in the management of mild preeclampsia is assessment of gestational age. If the gestational age is more than or equal to 37 weeks, then current woman should be delivered. If gestation age is between 24 to 36 weeks, management of mild preeclampsia depends upon maternal it's not. So we're coming to the management part of mild preeclampsia. The initial evaluation we should do and fetal evaluation we have to do. The first step in the management of women with mild preeclampsia is assessment of gestation age. If it is more than 37 weeks, then we can deliver the patient. If it is between 24 to 34 weeks, so if it is between 24 to 36 weeks, the management of mild preeclampsia depends upon maternal and fetal condition at initial evaluation and laboratory observations. If the disease evaluation is negative, then there is absence of disease progression to severe preeclampsia. Women with mild preeclampsia, we can continue pregnancy till 37 weeks. We have to do general measures like BP monitoring 3 to 4 times a day, body weight assessment daily urine dipstick evaluation, in the first avoided urine sample, proteinuria evaluation by doing 24 hours urine specimen, and the routine investigations like CBC, renal function test, liver function test, enzymes, either weekly or twice weekly, depends upon the medical condition we have to do. And we have to watch for net symptoms or danger signs in the patient. The feeder surveillance includes daily patient movement count, NST once or twice daily, AFP assessment weekly, and serial USG for fetal growth every 3 weeks once, and umbilical and unicellular artery Doppler for FGA patients, especially at least 2 weeks once. The next is antihypertensive treatment. The first line of antihypertensive in this condition is oral labetalol, given orally in doses of 100 to 400 milligram every 8 to 12 hours. The objective of treating severe hypertension is to prevent congestive cardiac failure, myocardial ischemia, renal failure, and ischemic and hemorrhagic stroke. Persistent elevated BP of more than 160 bar 110 is one of the most common indication for immediate delivery. Role of corticosteroids for fetal lung mortality. So if delivery is likely prior to 34 weeks, 2 doses of betamethasone, that's 12 mg intramuscularly, 24 hours we have to recommend. It is also considered for the fetus between 35 to 36 weeks also. There is no doubt that neonatal complications like RDS, intraventricular hemorrhage, and death are significantly reduced with the use of betamethasone prior to planning for preterm delivery. So this is the chart showing dose along with the drug along with dose and the side effects and contraindications. So the first thing is first and most common antihypertensive we are using during pregnancy is labetalol. You can use it up to 2400 milligram per day orally in 2 or 3 divided doses, starting at 100 to 200 milligram daily. Side effects include bronchoconstriction, so we should avoid this in asthma, pre-existing myocardial disease, decompensated cardiac function, heart block, and bradycardia. The next is nephridipine. It's a calcium blocker, we all know. You can use it up from 30 to 120 milligram per day, orally extended release, starting at 30 to 60 milligram per day. Should avoid sublingual form. The immediate release form should be used only for severe acutely elevated BP. Should be avoided in tachycardia also. Next is methyl dopa. We can use it from 500 to 3000 milligram per day, orally in 2 to 4 divided doses, starting at 250 milligram twice or thrice daily. Safety measures are up to 7 years. Safety studies are up to 7 years of age in offspring. The side effects include sedation, dizziness, and depression. Next is hydrochlorothiazide. You can use it from 12.5 to 50 milligram daily. This is second line or third line agent only. Next is delivery. It's the ultimate management of preeclampsia. So for decision hypertension of preeclampsia without severe features, vaginal delivery is preferred. Induction of labor, there is prostaglandins and vaginal delivery should be attempted in mild preeclampsia. Electronic fetal contact monitoring should be done, especially in cases we are suspecting FCR. BP monitoring, vitals monitoring, watch for imminent symptoms should be done throughout the labor and after delivery also. Recommended should be avoided in third stage, and third stage should be managed by oxytocin, prostaglandins to prevent BP health. Epidural analgesia and anesthesia is a procedure of is the choice of anesthesia in labor and cesarean delivery. Next is severe preeclampsia. So preeclampsia with severe features can result in acute and long-term complications for both mother and the newborn. Maternal complications like pulmonary edema, myocardial infarction, stroke, acute respiratory syndrome, coagulopathy, renal failure, retinal injury, everything can occur. In women with preeclampsia with severe features and gestation age less than 34 weeks with stable maternal and fetal condition, we can do expected management as well. In addition to the appropriate management of labor and delivery, the other two main goals are there. We have to prevent development of seizures and we have to control hypertension also. These are the conditions that precluding expected management. Mental conditions like uncontrolled BP, as I already discussed, persistent headache, refractory to treatment, epigastric pain or upper right corner pain, unresponsive to repeat analgesics, tissue disturbances, stroke, MI, HELP syndrome, new or worsening renal function, pulmonary edema, eclampsia, suspected placenta abruption or vaginal bleeding, in the absence of placenta previa. These are the conditions that preclude expected management. And fetal conditions like abnormal fetal surveillance testing, fetal death, the fetus without expectation for survival, like fetal anomaly, extreme prematurity, persistent reverse in diastolic flow in umbilical artery. So in all these conditions, we should not go for or we should not plan for experimental. Next is prevention of seizures. So for prevention of seizures, the most common medication we are using worldwide, especially in preeclampsia patient, is magnesium sulfate. We can use it in patients with severe preeclampsia, impending eclampsia, and eclampsia also. The most clinical studies suggest that magnesium is most commonly exert a specific anticonvulsant action on the cerebral cortex. It is also a peripheral anticonvulsant because of the ability to block neuromuscular transmission by decreasing acetylcholine release in response to nerve action potentials. So magnesium also decreases systemic vascular resistance and mean arterial pressure. At the same time, it increases cardiac output without myocardial depression also. Maxifide we can administer either by continuous intravenous infusion or by intermittent intramuscular injection also. The intramuscular regimen is we are following is Pritchard regimen. As we all know the dose, the intravenous loading doses 1 in patients with eclampsia giving 20 ml 20% magnesium sulfate. It is 4 grams. Slow IV in 3 to 5 minutes at a rate not exceeding 1 gram per minute. Next is followed by intramuscular loading dose. 10 ml of 50% magnesium sulfate deep intramuscular injection in the upper outer quadrant in each buttock using 3-inch 20 gauge needle. The IM should immediately follow IV loading dose in patients with convulsions. Next is maintenance dose, giving 5 gram of 10 ml of 50% magnesium sulfate solution deep IM injection in alternate buttock every 4 hours. So these are the things you should monitor while giving magnesium sulfate regimen. Urine output should be at least 30 ml per hour or 100 ml per 4 hours. Deep penile reflex should be present. Respiratory should be more than 14 beats per minute. Pulse oximetry saturation should be more than 96. Any change in these indices make it necessary to reevaluate the rate of administration. Magnesium sulfate should be discontinued 24 hours after the delivery or the last conversion, whichever occurs later. Guidelines for intravenous magnesium sulfate administration include loading dose of 30 ml of 20% magnesium sulfate, that is 6 grams in 100 ml of normal saline over 15 to 20 minutes. And maintenance dose of 20 grams of magnesium sulfate, that is 4 10 ml ampules of 50% solution to 1000 ml of normal saline solution and giving intravenously piggyback fraction and 100 ml per hour at rate of 100 ml per hour, that is 2 gram per hour. Disappearance of patellar reflex is important, but it is the first sign of magnesium sulfate toxicity. The reflex is usually lost when plasma concentration is 8 to 10 milligrams per liter. The external marker for magnesium toxicity is pulse oximetry. Treatment of respiratory depression induced by hypermagnesemia is intravenous calcium gluconate 10 ml of 10% solution. We should give it over 3 minutes. Calcium antagonizes the effect of magnesium by decreasing the amount of acetylcholine release, increasing the amount of acetylcholine release by action potential at the neuromuscular junction. This medication may cause maternal death from overdose, leading to respiratory failure or pulmonary edema, and its toxicity is associated with decreased myocardial activity, slow cervical dilatation, and increased blood loss at delivery. Max sulfate principally act with the muscle relaxants used for general anesthesia. During respiratory depression, hyporeflexia is observed only with the severe hypomagnesemia at delivery. Magnesium causes decrease in fetal heart variability also. The next drug we are using for prevention of seizures is phenytoin. Phenytoin has been successfully used for treatment and prophylaxis of eclamptic seizures. It acts by impeding the spread of abnormal activity from the seizure foci to the motor cortex. For the treatment of eclampsia, the loading dose of phenytoin should be 10 to 15 mg per kg. This is followed by maintenance dose of 100 mg IV every 6 to 8 hours. Benzodiazepines and phenytoin are justified only in the context of anti-epileptic treatment or when magnesium sulfate is contraindicated or unavailable in conditions like myasthenia gravis, hypocalcemia, moderate to severe renal failure, cardiac ischemia, heart block, or myocarditis. In all these conditions, we should not recommend magnesium sulfate. Antihypertensive treatment for acute management of severe hypertension. So we have to treat this acutely. We have to treat this severe hypertension because it will be causing cerebrovascular hemorrhage, hypertensive crisis, congestive cardiac failure, and it can trigger eclamptic seizures and abruption also. So objective of this antihypertensive management is to prevent intracranial hemorrhage and electroventricular failure. These antihypertensives should prevent seizures by lowering the perfusion pressure and preventing the vasogenic edema by infiltrating the cerebral arterial vasospasm that causes tissue ischemia and percapillary bleeding. So drugs used for rapidly lowering the increased BP include IV Libitlol, Hydrolysine, and Nifedipine. So the first drug of choice for acute severe hypertension in pregnancy and also in maintenance therapy is Libitlol. So it's a combined alpha and beta adrenergic blocker. The ratio of alpha to beta blocker is 1:3 in case of oral form and 1:7 in case of intravenous form. So for intermittent dosing, 20 mg should be given IV bolus in a 2-minute period. Additional dose of 40 to 80 mg may be given at 20 minutes intervals. It is recommended not to exceed 220 milligram per treatment cycle. Next is hydrolysate. It acts directly on the arterial smooth muscle to reduce vascular resistance. It is administered in the IV bolus starting at 5 milligram and increasing by 5 milligram every 20 minutes up to 20 milligram. Side effects include late decelerations because of decreased cerebrospinal perfusion and maternal tachycardia and palpitation. So it is contraindicated in myocardial insufficiency and heart failure. Next is nifedipine. It's a casplan blocker and it's an excellent peripheral vasodilator and good tocolytic agent as well. So dose will be starting at 10 to 20 mg orally and we can dip it in 20 minutes if needed. Maximum dose up to 180 milligram. Most frequent side effects are headache. It's not recommended sublingually. The risk of neuromuscular blockade with consistent concomitant use of ammonium sulfate and nifedipine is less than 1%. Blockade may be reversed by use of 10 mg of intravenous potassium gluconate. Other antihypertensive agents include methyl dopides, frequently used in chronic hypertension and gestational hypertension, mild preeclampsia, but it's not used in severe preeclampsia because of its delayed onset of action. So, coming to management of preeclampsia in gestation is less than 24 weeks. An attempt of expected management of severe preeclampsia in extremely preterm, that's less than 24 weeks actually with very high maternal and perinatal mortality and morbidity. So, it's advisable to allow early delivery in these patients to reduce maternal morbidity and prolonged hospitalization. So the gestation age is between 25 to 33 weeks. The decision between the delivery and expected management depends upon fetal gestation age, neonatal and maternal status at the time of initial evaluation, presence of labor, rupture of membrane, and level of neonatal and maternal services available in that facility. Only patients with severe preeclampsia with the BP criteria and those maternal condition is stable and fetal status reassuring are candidates for expected management. Maternal consequences of delayed delivery include intestinal abruption, pulmonary edema, eclampsia, HELP syndrome, cerebrovascular hemorrhage, acute renal failure, even maternal death as well. Fetal risk include hypoxia, perinatal death must be explained. Expected management at less than gestation less than 34 weeks. Strict patient selection criteria and adequate patient and neonatal care facilities are essential to prevent major disaster in women with severe preeclampsia are managed expectantly. Women with severe disease needs immediate admission and should remain intensive fetal and maternal monitoring and evaluation for minimum 24 hours. All patients in gestation less than 34 weeks should receive antenatal corticosteroids to accelerate fetal lung maturity and prevent intracranial hemorrhage and improve fetal survival. Immediate delivery is the only measure that interrupts the progression of the disease. So guidelines for the expected management with gestation less than 34 weeks. We should hospitalize the patient. We should do daily IGO charting, daily weight gain charting, antihypertensive management. If that antihypertensive treatment should start, and we have to give betamethasone, anticardiovascular to accelerate fetal lung maturity, and we should do laboratory test at least every alternate day or more frequently if needed. Daily fetal count, NST, weekly or too frequently depends upon the fetal growth, status, and liker. Umbilical artery and midsection Doppler twice weekly. AFI assessment twice weekly. USG for growth status of the fetus every 2 weeks or as needed. On the delivery part. So, mode of delivery is determined after considering fetal presentation, fetal condition, gestation age, and cervical Bishop score. Vaginal delivery is usually preferred. Prostaglandins we can use for a mode of induction. In cases of severe preeclampsia with gestation less than 34 weeks, induction of labor is always unsuccessful only in 80% of cases. Third stage should be actively managed oxytocin and incubator should be avoided. Hemorrhage is poorly tolerated in severe preeclampsia patient due to constricted intravascular volume. Come to the anesthesia part. Regional anesthesia is preferable. It's an anesthesia of choice in preeclampsia. And contraindication for regional anesthesia is the presence of coagulopathy and severe thrombocytopenia. Paxlovid has significant anesthetic implications because it prolongs the duration of non-depolarizing muscle relaxants. Coming to the postpartum care, all women with preeclampsia should be closely monitored. For the first 2 days of postpartum, BP you should monitor every 4th hourly and daily once for next 2 weeks. The antivenom can be stopped once BP remains normal for at least 48 hours. Don'ts in the management of severe preeclampsia. Don't attempt to normalize baby rapidly. Should not give diuretics before delivery. Can give a diuretics after delivery. Should not give diazepam to stop an eclamptic seizure. Should not push the padded tongue back to the throat. The following criteria should be met before transferring woman with preeclampsia to community care. There should not be symptoms of preeclampsia and the BP is on 300 or less with or without treatment. The blood test should be stable and improving, and we should advise medical review with the general practitioner or specialist after 2 weeks of transfer to community care. Avoid using diuretics or anti-seizure blocker in a breastfeeding woman, and we should advise women to achieve BMI in a healthy range before planning for next pregnancy. Advise women can have recurrence of preeclampsia if the interpregnancy interval is more than 10 years. In general, gestation hypertension usually resolves in the first postnatal visit, but preeclampsia can be taking longer time to resolve. And there may be initial decrease followed by rise in the hypertension between 3rd and 6th postnatal day. So, these are the following above are the advices we should give a woman before discharging the patient. Thank you.
I got seen. I fallen.